Okay, I think we're ready to start. So I'm going to hand over the reins to Marwan. Thank you.
Thanks, Ali. Good afternoon and welcome to everybody. My name is Dr. Marwan Alderwood and I'm delighted to be your chair for today's webinar. I work for Connect Health as the Director of Clinical Delivery. I also work for East Lancashire NHS Trust and Leeds Rhinos. My role involves ensuring clinical services are delivered safely, effectively and to the highest standards. I'm also clinical and I continue to see patients at Connect Health and in the NHS. We've been running the Connect Health Change webinar series since July last year, and this is our 18th session. Topics covered previously have included chronic pain, long COVID, service redesign, first contact practitioners, education, quality improvement and mental health. The next ones in the series in the new year is on mental health, followed by health inequalities in March. And all the past recordings, along with the Q&A summaries, can be found on the Connect Health Change webinar. So today's topic is unwanted variation. We've got a really impressive lineup of speakers here today, and you can find their full biographies on the webpage. Each presenter will speak for 7 minutes, followed by any immediate questions, but we'll take the majority of questions at the end. And I really encourage you to post your questions in the Q&A section. Unwarranted variation or geographic variation in healthcare service delivery refers to the differences that cannot be explained by personal preference, illness, medical need, or the dictates of evidence-based medicine. Unwarranted variation is widespread throughout the UK, affecting patient outcomes, service costs, and overall productivity. Lord Carter highlighted an opportunity to save up to £5 billion in his 2016 report. But perhaps more importantly, the existence of persistent unwarranted variation in healthcare directly impacts on equity of access to services, the health outcomes of populations, as well as the efficient use of resources. In this webinar today, we'll be asking the questions: how bad is unwarranted variation? And what are the latest insights? How has COVID impacted unwarranted variation and inequalities in health outcomes? What is the latest learning and data from Get It Right First Time? And how has it been applied by the best MSK collaborative? And finally, what more can be done to improve outcomes and tackle waiting lists? So without further ado, it gives me great pleasure to introduce our first speaker, Fiona Ottewell, who is the delivery partner of the North East and North Cumbria ICS locality team, and she's going to be talking about the national perspective.
Thanks, Marwan. Great to be here. Jen, if you can just go on to my slide, because what I'm hoping with this selection of slides is that I'll be answering the question, does unwarranted variation offer us productivity opportunities, by saying that it helps us to ask the right question when we're considering areas that could be improved as a pathway. So I'm just starting off with this first slide to understand why we are here. And part of the reason we are here is because of the significant backlog that we've got around our patients who are waiting for trauma and orthopaedic procedures who've been on the waiting list for more than 52 weeks. And you can see the variation that's depicted here with each of the ICSs across the country. This data is from September 21 and it is available on Model Health Systems. If we can move on to the next slide, please, Jen. What I'm really keen to emphasise, though, is that we look at this through a health inequalities lens. And I think this is where the real opportunity for productivity comes, because we know that patients, that what this slide shows is the variation in terms of the index of multiple deprivation for each of the ICSs across England. And we know that patients who live in more deprived communities will tend to present later as an emergency rather than earlier in the pathway, where there would be an opportunity to offer less resource intensive but also more effective preventative strategies to manage their problem. And so I'm sure that you're aware of the next slide, which is a cartoon that shows the difference between equality, equity and the reality. And I would argue that sustainable productivity is addressed through looking at inequalities and shaping the offer required by those populations. And so what you see here is on the first cartoon, you see equality where everybody's been given the same size stool to watch the ball game. Sorry, if you can go back there, Jen, thank you. The second cartoon demonstrates equity where a degree of personalisation has been applied and an easy movement of resources to ensure that everybody has got the same view of the ballpark, as opposed to the reality, which is sadly often at play. And so on to the next slide, which looks at our spend on spinal back pain. And obviously any MSK team will see a significant proportion of this within their caseload. And what this slide shows, and I'm sorry that it's such old data, but the top bar graph shows each CCG within the country. And the whisker lines are the vertical lines on each of those bars, and they denote the confidence intervals or the level of statistical significance that this data represents. Now, in terms of variation, we see a significant amount of variation, and the bottom bar chart demonstrates that variation that exists in demographically similar peer groups. So we see that there is variation, but we can't say whether it's warranted or unwarranted until we understand the narrative between whether that spend is high or low because resources are being overutilised or underutilised, both of which would represent an opportunity for productivity, and both of which would represent unwarranted variation. So I'm just going to move on to the next slide, which looks at MRIs, and you see a lot more variation here. And again, the same principle applies, that underutilization or overutilization does represent unwarranted variation, but we have to understand what is the narrative for that particular health population. But even though this slide is very old, given the significant pressure on diagnostic services, you could argue that we should only be using MRIs when it's absolutely clinically indicated. And we can see here that there was a CCG in 1819 that had significantly higher use than its peer group and than the rest of the country in terms of its use of MRIs. And that would be an opportunity for a productivity conversation, in my opinion. On the next slide, it's a little bit more clear cut, because what we're seeing here is the picture around resources spent to support fragility fractures. There's much less variation, but there is still variation. And what we have here is a red box that denotes that for a particular CCG in that demographic peer group is spending £1.2 million more than its demographic peer average. Now, obviously, the more you spend on fragility fractures, you could argue that spend could be avoided if you had an infrastructure in place to prevent, to diagnose, or to support that community at risk of fragility fractures. And so I would argue that you could say the CCG that is at the very top of that bar chart could have a conversation with the CCG who is at the bottom of that bar chart on the bottom graph to understand what services are in place within their health community to support people with fragility fractures. And that whole saving of over £1 million would not be a saving into the CCG coffers, because some of it would have to be applied to resource the services required to support fragility fractures. But this is the sort of productivity opportunity that I would argue is released through looking at variation. And on the next slide, which is my second to last slide, Jen, in case you think that I'm overrunning, is just to talk about opioids. And again, we see significant variation here, and I wanted to flag it up, even though it's very old data, because we know that there are patients who are on long-term opioids who will possibly not have the best optimum benefits from that because of the long-term complications associated with opioids. And so I would argue that by looking at variation, there is an opportunity for the CCGs who sit in the top decile to consider a focused support conversation with the multidisciplinary team that look after that MSK population around the potential for a very brief intervention or very brief advice for any patients that they discover who are on long-term opioids. And so I'm just going to conclude with my final slide, which looks at a set of references. Obviously, these are all included in Andy's best MSK strategy, which I know he will be referencing later on. But I did want to particularly draw your attention to shared decision-making resources. Shared decision-making is very strongly referenced within the best MSK strategy. But in my opinion, if a patient has undergone a robust, effective shared decision-making with their clinical caretakers, then that decision about any variation within their individual pathway would, in my opinion, always be a warranted variation, because it was what they wanted and what, in discussion with their clinician, was felt was needed. Thank you very much.
Thank you, Fiona. That was a really interesting perspective, linking back pain, MRIs and opioids. It's fascinating to see the variation that exists. A question from me is, how do individuals get access to this data for their own patch?
Yep, so basically every CCG will have business analysts who will have access to this data. If you haven't got that through your local CCG, then your locality team will also have a team of analysts who will be able to share this information, because it's in their best interest to be working in collaboration with you to look at this data. And if you're still hitting barriers and you still can't get through, then my contact details are there and I'd be very happy to signpost you.
Thank you, Fiona. There's just a question coming. I think we do have time, which is, does that conversation between CCGs who are outliers actually happen in order to learn from one another?
Yep, so it is happening. It happened more pre-COVID than post-COVID, because there are so many other significant conversations happening post-COVID. But we have got that. Certainly that sort of conversation is definitely happening at CCG level. And even as we move away from CCGs, as we move into ICSs, that's the sort of conversation that is very much live in terms of managing the demand that we've got at the moment, and a really, really important conversation to be happening.
Thank you. And just one more question from me. I think we have time. This is clearly a big opportunity for spotting inequality. What should we all be doing about it in our individual domains?
In my opinion, we should all be thinking about how do we make sure that we personalise the offer. I think that we do have an ability to personalise the offer to individual populations, to individual patients. And I think that it's understanding that different horses will run on different courses, and we really do need to be as flexible as we possibly can in terms of our healthcare offer.
Thank you so much. The next, I'm keen to introduce the next speaker, who's Professor Tim Briggs, CBE, who is Chair of Getting It Right First Time and the National Director for Clinical Improvement for the NHS. He's a consultant at the Royal National Orthopaedic Hospital, and he's going to be talking about the latest learning and priorities from Getting It Right First Time programme. Over to you, Tim.
Thank you very much indeed. Could I have the next slide, please? Jennifer. Lovely. So I'm going to talk about how girth supports the challenges of elective recovery. Next slide, please, Jennifer. And it's great to see Fiona using the data from the model health system, which was Model Hospital working with girth to produce the model health system, which I think is going to become the way we look at things going forward, and we want everybody to engage and use it regularly. So the high volume low complexity programme came from work we did in London, and you can see we did it across 6 specialties, which represent 63% of the combined waiting list and 70% of the 52-week waiters. And as we know, there are 5.83 million on the waiting list, both admitted and non-admitted. And just to let you know that we've got 330,000 patients waiting over 52 weeks currently, but we've been there before. Just remember that. And that was in November 2007, when it was as high as 587,000. So we can solve it. And I'm hopefully going to show you one way that we can help that. Next slide, please. This is what we need to do to support elective recovery, and I think it's really beneficial that we've now got the girth programme, which has now published 31 national reports, which tells us what good looks like in those specialties. And we've got another 9 reports coming out in the next 2 or 3 months, which will allow us to look across the breadth of medical surgical specialties and say, how are we going to do things different, and what are we aiming for? What does good look like? So we've got to have the appropriate evidence-based treatments with shared decision-making. Hot, cold elective hub sites are going to be crucial to elective recovery. And we want to standardise pathways, something before we took on this programme that had never happened really in the NHS. We want best in class. We've got to reduce variation, complications, readmissions, and increase our day case rates where appropriate. And the HVLC programme is aiming for 90% of the activity be as day case. And the question we want to ask is, are we using our current facilities efficiently? And can we improve theatre productivity and work smarter? Next one, please. So this is the gateway in orthopedics, where I've got the red rectangle. This came from the Girth Orthopedics National Report. This shows what good looks like, where it puts us in the top decile. And what it allows ICSs and STPs and trusts to do is benchmark now where they sit in that and what they've got to do to aim to get to the top decile to make sure that we are giving our patients the best experience and squeezing out unwarranted variation and complications. Next slide, please. We produce 29 pathways, and you can see in orthopedics and spines, it's 11 of those. And I'm very much focused in the secondary care sector because of the real issues that we've got in terms of delivering the large weightiness that we have. And Andy's going to talk about upstream and downstream from that. But these were produced in 7 weeks using the profession, signed off by the colleges. And it was an amazing piece of work that brought everybody together as a result of COVID to do something really differently. Next one, please. This is an example of an orthopedic pathway. This is just therapeutic shoulder arthroscopy. And you can see I'm concentrating on list for surgery, day of surgery, and day case inpatient management. And Andy will talk about discharge and follow-up and primary presentation. So we are really now using these pathways and going end to end and joining it all up. Next one, please. And what we also want is you want day case principles. So all those pathways, 90% of them we want as day case, and there is no reason now why we can't do that. And we know that day case surgery will get a double win because if the cases are done as day case, it frees up inpatient beds to do the more complex work. And we know we can get significant theatre throughput through day case work. Next one, please. We also want to see improved productivity, and these are the principles we wanted. Start your lists on time. Work the whole of the list. Make sure your intercase downtime is low. Make sure that your time you're sending for patients and turnaround time is low. And also what we've done, you can see on the right there, that we've put in the number of cases that we want to see now on one of these HVLC lists. And now this data is being put into the model health system. For me, it's an absolute game changer. This data is being refreshed every 2 weeks in terms of theatre productivity and allows us to track how we're doing right across ICS, national and trust level. Next one, please. We want hub sites. Where are we at the moment? So we're just doing a survey of every single ICS and trust in the country. Who's got hub sites? Are they active? Are they inactive? We've got 88 that say they are active. We're running a questionnaire at the moment to really define and work out which are really working, which aren't. About also single specialty or multiple specialty. Are they standalone or are they linked to a hospital? And this again will give us an opportunity to see where there's a deficit, because there is going to be money, £1.5 billion available to develop hub sites, which is going to be crucial to maintaining and sorting out elective recovery. Next one, please. And how do we measure our impact? and we've already heard from Fiona, and this is what you've got to look at. We should be looking, every one of us, at our model health system data every week, at least once a week. The volumes and the data is going to be refreshed every month, the theatre data every 2 weeks. And this for me is an absolute game changer. There's going to be no hiding from the data to drive recovery, and no excuses why we haven't looked at the data. And I think this is going to be an important part of how we deliver what we need to do for our patients. Next one, please. So this is an example. So this is going to be the data you're going to see regarding your theatres, right? Each of these is an ICS where the thicker bars are, but you can drill down to the thin bars where these are individual trusts. System level late starts varies from 10 to 65 minutes. Intercase downtimes at providers varies from 15 minutes to 60 minutes. Late starts at provider level from 5 to 140 minutes. Early finishes anywhere between 5 and 150 minutes. So you can see there are significant gains we can make by just being more efficient and using our facilities better. Next one, please. And what have we done in London? So I think this really says it all. In London, we started this in September 2020. What have we achieved? We're the only region to reduce our 52-week numbers for HVLC by 7%. Every other region, it's gone up by between 18 and 135%. We've got clinical buy-in. It's clinically led, clinically driven, and that provides the real impetus for clinicians to get really involved. Our clearance times, we have out of the 6 specialties, 4 of them have the lowest clearance times out of all the regions. ENTs were second. We've got more work to do around general surgery, but now we know that, we can focus on that. And if you look at what we've achieved, we're now in London achieving more activity than we were before the HVLC programme. And if you then compare the HVLC work with the non-HVLC work, you can see that we've reduced those in London by 7%, whereas there's been a 19% increase for the non-HVLC. So we know this works. Next slide, please. So for me, data is going to be absolutely critical. Using that data, sharing it, working smarter, using our workforce in a very positive way will enable us to deliver what we need to do. We've done it before in 2007 to about 2012. We now need to do it again, but we're in a much better place. Much more day case work can be done, and we've now got the data to back it up and drive change where we can use and look after our workforce, use them effectively, but actually use them appropriately. Thank you very much.
Thank you, Tim. Very exciting when you're talking about hub sites and particularly the impact of using data. A question from me is, we've known about variation for many years, but it's only now that we're starting to address it. What's been the catalyst for this, and is it sustainable?
So for me, I would say it's the girth program. So remember, it starts off in orthopedics. It's now 40 specialties. We've got 60 national leads, 31 national reports. We now know what good looks like. Second thing is getting that data together, getting it refreshed regularly, getting into the model hospital with girth, the model health system, defining where we want to be, but now getting data and trust returning data so we can look at outputs, quality, efficiency, productivity, and theatre uses, using this data to work smarter. And then how we involve the independent sector in this elective recovery, using this data to drive real change. I mean, for me, that is the absolute nubbin of where we've got to and where we need to go.
Thank you. And just one other question from the audience. Why is London so far ahead of the rest of the country in respect of the 7% improvement in 52 weeks waits?
It's quite simple, really. So I was asked by Sir David Sloman, who's the regional director, and Vin Dewaka, the regional medical director in London. London got hit hardest by wave 1. It was April 2020, we're down to 11% BAU. And I was asked as the national director of clinical improvement and the girth lead to go and help them transform their surgical service. So we developed this model together and trialed it in London. And on the basis of our outputs, we've now got the go-ahead to deliver it nationally. So that's what we're doing. So that's why London is further ahead than the rest of the country. And we developed hub sites. We've got 43 hub sites in London now, some of them working at 160% BAU. And so we've demonstrated that model works as well. So that's why we've got the go-ahead to drive it and take it national.
That's great. Thank you, Tim. Moving on to our next speaker, who is Andrew Bennett. He's the National Clinical Director for Musculoskeletal for NHS England and Improvement. He's a consultant physiotherapist at Sutton Health and Care, Epsom St Helier NHS Trust, and he's going to be talking about best MSK, latest achievements and next steps.
Thanks. Next slide, please. Yeah, no, thanks, and great to follow such interesting and pertinent presentations from Fiona and Tim. My focus very much is on the system level and restoration and improvement in that space. Next slide, please. So look, I'm stating the obvious, but you know, we have a very, very complex challenge. We had variation in access to outcomes and experience pre-pandemic, and this has been complicated by the unintended consequences of our pandemic response, as well as those new challenges that have developed as a result. And we need to restore services, but further to presentations already given, we need to do this through the lens of improvement, but accounting for local population needs and resource availability. Next slide, please. So informed by our vision in MSK to promote best lifelong MSK health for all, the Best MSK Health Programme aims to coordinate and co-produce the strategy to restore and improve MSK provision across the whole system, integrating the NHS operational priorities, the ambitions of the long-term plan, and delivering through the emergent integrated care system and primary care network structure. So we aim to improve productivity and performance at system level to reduce variation in access, outcomes and experience for those with MSK conditions. Next slide, please. I think as already reflected in the previous presentations, this requires whole pathway transformation across primary and community care, aligning with the independent sector, balancing urgent and emergency care with elective care provision, and making best use of digital resources, new technologies and the beneficial exchanges we've experienced during the pandemic. We need to mitigate risk, we need to control demand, and we need to make best use of capacity, but they are all quite cold words. We have to have a constant focus on high quality care and optimal patient experience. Next slide, please. And of course, this aligns with the ambitions of the emergent integrated care systems. Delivering best MSK care across a whole system requires integration between physical health and mental health services, with social care services and with the third sector. And we want to enable MSK leads at ICS level to co-produce their MSK strategy, adapting the overarching principles that we are sharing in the previous presentations to meet local needs, accounting for resource availability. And our focus within the Best MSK Health Programme is the health element of this triple integrated model. Next slide, please. So this whole pathway approach builds on the excellent work developed in London and the work and envelopes the work going on in the high volume, low complexity programme referred to. It involves integration between primary, community and secondary care across the pre-hospital, hospital and post-hospital space. It's focusing on building on the work done to transform the whole system pathway for orthopaedics, spinal services, rheumatology, falls, fragility, fractures and osteoporosis, and children and young people. And to do this, we need to enable best primary and community care delivery, optimal use of diagnostics, and envelope that way in a model of personalised care, as Fiona alluded to, with shared decision making at its heart. And we are collaborating with a range of NHS EI improvement programmes across primary, community and secondary care to enable this, as well as working very, very closely with the secondary care focus programmes as shown on this slide, and with TIM and girth, as well as HEE, NHSX and public health colleagues. Our ambition is to join all stakeholders up in MSK in this whole pathway transformational approach. And indeed, we're working very closely with both professional and patient stakeholders to fully co-produce this strategy. Next slide, please. And so what are we actually doing? Well, our focus is on balancing optimizing delivery through high quality leadership, which we enable, and evaluation and best use of data, as Tim alluded to, but across the whole system. We are fully aware that we have different challenges of data, particularly in the primary and community care space. And we have consolidated our overarching strategy within our high impact strategy document that's available on our NHS Futures website and is aimed at anybody in a leadership role now who is focused on restoration and improvement to take forward ambitions in their sector. It contains 49 recommendations relative to our ambitions across MSK, an overview of how we're going to take our evaluation strategy forward, and resources to enable delivery. And this is an iterative document. It's work in progress. It's being informed by work going on now, and I'm sure many people on social media will have seen the spinal infographics we produced for MRI. Aligned with this recommendation, a lot of work is ongoing, but we've also had a lot of feedback. So this document will be adapted and developed as we go, and indeed there is a new version coming out imminently. Next slide, please. But also it's about using data, as we've referred to in the first two presentations, and aligned with our high impact strategy. Our focus now is to make best use of the metrics that we can collect now to evaluate whole system performance and productivity, and particularly in the outpatient space. And we can use data with regard to outpatients activity, relate this to measures of equality, diversity, inclusion, relate this to the right care measures we were talking about and the focal secondary care measures to help evaluate whole system performance and productivity, to identify those areas which are most challenged, to inform deep dives, to identify where those challenges are. And those challenges are variant given the heterogeneity of our system. But if we work with those different systems that are challenged, we will identify similarities in issues and enablers and levers that we can pull, that we can then traverse to the whole system in England as a whole to enable equitable access, optimal experience and optimal outcomes. Next slide, please. So look, out of a challenge comes opportunity, and I think that's referred to in all of the presentations that we've had. We've got an increased focus on MSK conditions. It's gone up the policy ladder, and this programme is evidence of that, and that's secondary to some of the hard work that's been done with girth too. And you know, we've also got an ethos of integration, collaboration and co-production that's very much developed during the pandemic. And so we need to, aligned with the preventative and population health approach that ICSs bring, really grasp this very challenged time to restore services, but to do that, to build a foundation to improve the quality and value of our provision, accounting for the variance that we had pre-pandemic. And I think what is unique in the MSK world is the integration we have that is looking at this as a whole system problem and a whole system challenge and a whole system opportunity, and not in siloed spaces. Thank you.
Thanks, Andy. Really interested hearing about, you talk about the seamless pathway across primary, community and secondary care, and then particularly using data to ensure quality is driven at the heart of this. A question from me, what are the key enablers to deliver impact in reducing variation in access outcomes and experience locally?
Yeah, it's a really good question. So look, there were three pillars I talked about. Firstly is delivery. So we can build on the work that's being done with regard to pathways, but also ensure that the right resources are in place aligned with those in primary and community care, both at the front end and the back end, and do that working with NICE, working with CQC and working to optimise commissioning. We then have the evaluation piece, and with regard to data, we have good data in the secondary care space. We do not have good data in the primary and community care space, so we need to look at how we can evaluate the whole system better, integrating the data across these different spheres. And then with that, we need to focus on leadership, because to bring those things together, we need to enable those who are MSK specialists in local lead roles who have the best understanding of population and resources to adapt and adopt these strategies to meet local leads. We've got areas working very well. We've got areas that are challenged. We don't want to hamstring the ones working well, pardon the pun, at the expense of those who are challenged. So it's about creating this leadership community and learning system to deliver. And then, of course, at the heart of that is co-production. Fundamentally, what are we trying to do? We are trying to offer the best value care for patients. And to do that, we need to ensure that patients are engaged just like everybody else.
Brilliant. Thanks, Andy. And thanks everybody for your questions so far. Please do keep them coming. I'm delighted to introduce our next speaker, who is Freddie Cavender-Atwood, and she is the Policy Manager for Health and Care for the MS Society, and she's going to be talking about the patient perspective. Over to you.
Hello everyone, thanks for having me. And you may have noticed I'm slightly the odd one out here and talking about a neurological condition rather than a MSK, but hopefully, and I believe that a lot of what I'm going to talk about in terms of patient experience does actually apply to a lot of other long-term conditions. And we work very closely with lots of other long-term condition groups and share those experiences. So the next slide, please. Oh, and the next one. Thank you. So firstly, just to say, 1 in 6 people in the UK have a neurological condition. 130,000 of those have MS. It's a progressive and an unpredictable condition, and it impacts aspects of all aspects of people's lives, meaning they have contact with lots of different parts of the health and care system. So again, like a lot of other long-term conditions, the experience I'm going to talk about are reflective of that. So I'm going to start with just a few quotes from people living with MS. I think give you a good sense of the ways in which unwarranted variation affects patients. So first, this is Paul, and he has MS and he suffers with painful spasticity, and he wants to try a treatment called Sativex, which he's clinically eligible for. So just to read this out, Paul says, "I know that Sativex has been approved and could help. I just want the opportunity to try it. I might get a full night's sleep and not being constantly thinking about pain. I've been in touch with someone on Facebook. He's in Blackpool and has been prescribed Sativex. Why can't I have the same? What's the difference between living in Blackpool and Bradford? There's no clear explanation. It's a postcode lottery." So this is a really obvious example of the impact the geographical variation has. I think the sense of injustice that many patients have and the feeling of having to fight the system, which has an emotional but often also a physical impact as well, where people are struggling with symptoms like fatigue. And fundamentally not knowing what you're entitled to, what you should expect, because national bodies say one thing and the local reality is different, is a very frustrating experience. And in this example, the reasons for this variation between Blackpool and where Paul lives is twofold. One is very obviously funding. It's local CCG decisions to fund this treatment or not. But there's also varying clinical attitudes. Some clinicians have kind of lack of confidence or misconceptions about the treatment. And obviously that's an area where there can be efforts to try and mitigate those issues. Next slide, please. So this is another quote here from someone called Caroline, who has progressive MS. She really needs physio and other sorts of services to help keep her really mobile, independent. So to read her quote, she's saying, "I can't access the services I need. I have to find and pay for services myself, like physiotherapy. It feels like there's just a lack of options for me due to my progression. Wiltshire doesn't seem to have anybody that specialises in MS at all. Swindon or Salisbury. No one appears to have a neurology department. People have to travel to Southampton to see a specialist. It's quite concerning." So for someone with advanced disability like Caroline, having to travel a long way to access treatment because it's not available in her area is clearly very difficult and it's unfair. And this is just something we hear an awful lot of, unsurprisingly. Final quote here is from Roxy, also living with MS, and she's had a lot of difficulty speaking to professionals that she needs support from. "They obviously want to do the best job they can, and not being able to see your patients is difficult. Staff don't get paid enough, they don't have enough time, there's not enough staff, and there's not enough things in place to help them do that job more efficiently." I think Roxy touches on many of the factors driving variation that we see in MS. For one, it's harder to recruit staff in more rural and deprived parts of the country. But she also points to the fact that it is possible, as some of the other speakers have talked about, to unlock capacity by supporting professionals to move to more efficient ways of working. Next slide, please. So I'm not going to give you lots of numbers and examples demonstrating that unwarranted variation exists and it impacts patients, because I'm sure that won't surprise you and you've heard a lot already. The recent Getting Right First Time report on neurology goes into a tremendous amount of details, really excellent, and recommend looking at that. But just to give you a flavour, this graph, and sorry, some of the numbers are obscured here, I couldn't manage to fix that. it shows variation in the proportion of people with MS eligible for disease-modifying treatments in England, and how many people are able to take one of those. And you can see the variation between different regions there in England. And there's significant variation in what drugs are used, the specific drugs that are used, and how much is spent on them, as the recent girth report shows. And there's no obvious clinical reasons for this, but it means that there are patients out there who, we believe, should have started on treatment to slow the progression of their disability, but aren't for kind of unexplained reasons, despite the fact that these drugs are nationally funded. So, evidence shows people with MS experience differences in care for lots of different reasons. The type of MS they have, and people with progressive disease tend to be more poorly served because there aren't the rehabilitation services in place, and also because services are really at capacity dealing with other forms of MS where there are more drug treatments available. So the pathway is very much focused on that. Another factor is obviously where people live and how close it is to a neuroscience centre. We know that those who live closer to one of these specialist centres generally have better access to better care. And as already been mentioned, whether people live in a deprived community is a big factor too. Next slide, please. So finally, what is there that we can do? A lot has already been said. I would say, there's a lot to gain by addressing unwarranted variation in neurology. Agree with what's been said about better use of the workforce and data being vital. But I would say, some of the data that has been presented for MSK is amazing, and we don't have that routinely available in neurology. We don't have those outcome measures, for example, at local level. And the girth report identified this as a real challenge. If we're going to understand variation and how to fix it in each area, then we do need to see that picture in the data and have the data to do that. Final few thoughts, the health and care bill and changes to specialised commissioning should make a real difference in neurology in terms of trying to deliver care closer to home, addressing those travel issues that people have told us about. But I would say, in changing the structures and the funding mechanisms, we need to not lose sight of patients and delivering better care for them. And I think if we don't involve them fundamentally in ICS bodies, then we could actually continue unwarranted variation in a different form, but it won't go away. So it's really important patients are involved at that level. And then on this slide here are just some links really to how could you seek to understand and address variation in neurology if that's something you're interested in. But obviously these are relevant to a lot of other conditions too. Girth, right care. We've also highlighted there, a lot of patient organisations do have surveys of patient experience. The Neurological Alliance has one, and they have a regional comparison tool that you can look at. We've also highlighted that there is lots of work going on to articulate optimal clinical pathways within NHS England, which is really fantastic. And I think having those will really help ICSs understand what good looks like. And then I've also linked to one of our reports as well. And then the final slide is just very specifically, that as a charity, we try and do work with local areas and professionals to help them tackle some of these challenges too. So there's some contact details there if that's your area. So thank you very much.
Thank you, Freddie. Your presentation really hit home, and it helped me reflect on a recent high-profile case I was involved with the rugby player Rob Burrow, Leeds Rhinos. I was his doctor at the time, and dealing with his case really kind of shed a lot of light on how much variation there was to specialist neurological services in the region. So thank you for that. A question from me is, how should the NHS involve patients and communities in efforts to tackle unwanted variation?
Yeah, it's a good question. So I touched on the integrated care systems and the need to involve patients there. I think it's really important that at all levels, those bodies have representation from different types of community groups on them, and that's something I know the kind of guidance that's been drafted around those changes is reflecting. and we would like to see that really strengthened, so it's not an optional to involve patients and patient groups, and particularly, you know, engaging with those communities that carry the highest burden of ill health and disability, that may not be the ones who put themselves forward for opportunities to be involved. So you need to proactively kind of seek those voices out.
Thank you so much, Freddie. Moving on to our final speaker, I'm delighted to introduce Dr. James Hopkinson, who is Joint Chair and Clinical Lead for Notts and Nottinghamshire CCG, and he's going to be talking about the ICS perspective and what more can be done.
Afternoon, everybody, and thank you, Marwan. You'd probably all be pleased to hear that my talk's pretty consistent and aligned to the previous talk, so I'm very grateful to my colleagues for such fantastic presentations, but unfortunately you have stolen most of my thunder. Thank you, Freddie, as well. Patient perspective is incredibly valuable, and I will reflect on that myself. I'll try and add a little bit of flavour from a CCG or ICS perspective as we're trying to think about now. Can I have the next slide, please? So, on my keep it simple, stupid approach, unwarranted variation. We all understand and accept variations to be expected. We're not the same. One approach for an individual will and may be different to another to achieve a good outcome. Now, outcome for me is a key word here. We need to be thinking about consistency of outcomes, not consistency of treatments. Outcomes divided by cost gives me a measure of value, and I'm trying to think in the terms of value. As has already been discussed in some of the previous talks, unwarranted variation describes a difference in practice that are not from patient-focused, individualised choices about their care. And the examples were things like different surgeons seeing the same cohort of patients having statistically different operating rates, considering that as unwarranted variation. So, in my view, unwarranted variation is actually describing waste. Waste, I think we should think about as possibly financial, which is the way we normally think about it, which we're doing something with a cost that's unnecessary or maybe not a priority. And that's what the sort of leaners we've been discussing so far. But there's also the big opportunity cost. What we're actually doing potentially is denying or delaying another individual's care as their slot or their money is used elsewhere on people less needy. Next slide, please. So for me, the role of the ICS or the CCG is maximising health outcomes for our citizens. So that is getting our most bang for our buck, if you like, and trying to do this in the most equitable way, which means we need to be focusing our care on those who are most in need. Next slide, please. Now, to be able to treat those most in need, we need to have good clinical practices, which will need clear and consistent clinical guidelines backed up by strong evidence. So we've got things like girth helping us with these processes. But to be clear, what I'm not saying is that this means doing the same everywhere. Different populations will have different needs and different focuses, and we need to think about how we invest our money where to make sure that we get the best bang for our buck, as we said before, focusing on outcomes for our population. We need to be able to prioritise patients by need. Now, within specialties, we've got the RCS guidance, which came in really helpfully during COVID, which helped us prioritise, for example, within orthopaedics or within ophthalmology or any other specialty, which things should be done earlier relating onto their importance, which may be related to whether it was malignant or urgent and the effects on our patients' lives. And the point here is to get away from working through waiting lists in order. Next slide, please. So for me, this all sounds quite easy, but I've been talking about this for a long time, and it is actually really, really hard. So I've just thought some way of trying to bring it to life, just some of the examples of the challenges that I see regularly. So at the moment, politically, there is a massive drive and desire to treat the long waiters. We are focused on by our regulatory bodies to make sure we achieve those targets. But the reason why they're long waiters is often for a reason. Waiting a long time doesn't make you the most needy in a population. We also struggle to compare across specialties. So is a new hip in someone that can't walk more valuable than the cataract for someone that can't now see? It's often really hard to see true unwarranted variation and separate it from warranted variation, especially in the world of increasing subspecialisation, where clinicians may not have comparable patient groups, and therefore the proxies that we've tended to use in the past of conversion rates, for example, cease to be as helpful. But when there is variation, we need not to assume it's either warranted or unwarranted, but it should be making us ask the questions and make sure we're looking at it. I hope that sounds like a sort of coherent view and it makes sense. And that's really all I wanted to say. Thank you.
Thank you, James. A question from me. What do you think would make the most difference to reducing unwanted variation?
So it's been mentioned in some of the talks before, but I would personally like to see a much greater focus on shared decision making. I personally hate the term shared decision making because it's become a thing rather than a process. And by shared decision making, I don't mean the completion of tick boxes or forms by the surgeon when they're consenting to make sure we've explained the risks, but I mean the development of a better clinical conversation by all people who are involved in patient care at all points in patient pathways. So I think too often patients arrive at surgeons having been told that they need a new knee or a hip, and we've already preconceived an outcome. I think we've got a responsibility to help patients understand their condition, understand their options, including what will happen if we don't do anything. We need to empower our patients to make the informed decisions about their own care. My real bugbear is the damage that, as I described just then, is that when someone early in a pathway can, with a flippant comment, who's often a GP like me or a physio, with phrases like, "You need a new knee." And I think we need to change the entire narrative at all touch points of patient care.
Thank you, James. We've now got some time for a Q&A panel with the speakers. And to start off, I'm going to ask you all to provide a sentence or two on the following questions. And I'll take you in the order you've spoken today. What's the one thing you'd change to improve outcomes for people experiencing unwanted variation? And that's to Fiona, first of all.
Thanks, Marwyn. I mean, you asked us to prepare this before the presentations, and I'm just going to echo what James just said. If we really get shared decision making as effective and as robust as possible, I believe that will make the difference, and a sustainable difference that we are seeking in our productivity challenges.
Thank you. And Tim?
Well, for me, it's the data. The data is king. There's no doubt about that. And it's not just having the data, it's people using the data. So if we had every healthcare professional looking at the data every week, whether they be in primary care, secondary care, community care, and when we've got the primary care data sets that Andy's working on the community, that is a game changer, because we can ask the question which we've never been able to ask before: why do you have unwarranted variation? Why do you have theatre productivity that's not satisfactory? And you can go along the whole pathway asking the question, and that what it also highlights is areas and places that are doing stuff well. And what we need to then learn from them is just put it into practice and industrialize it, and the data will show you that.
Thank you. And to you, Andy.
Yeah, agreed with both, and I don't really want to repeat. Shared decision making is absolutely key, but so is the right supportive self-management, and that's got to be adapted to local population needs and local resource availability. So it needs to be underpinned by a population health approach, which of course ICSs are designed to enable. But to enable that, it's about the local leadership to co-produce the strategy.
Thank you. And moving on to Freddie.
What can I possibly add? I think that's everyone said it already, really. Yeah, involving patients. I think not making assumptions about the reasons, for variation or how to solve them without asking patients. And also, I think, to my point about people feeling this burning injustice, I think kind of not finding a way to not shy away from that. So where there are good things being done to tackle it, patients know that you're aware of that and that something's being done. And I think making them aware of what their entitlements are at that local level, because often people don't know what they should be entitled to.
Thank you. And finally, James, I think you've already answered it and people have already agreed with what you said, but anything further you wanted to add?
So just reflecting on what I've heard, I think for me there's something about education and culture, so that we all actually start to believe it's all of our problems, so that we all, as Tim said, we're all looking at the data and we're all engaging in the patient conversations. this is too hard to pick out a unit or a particular group of people to be responsible for this. This is everybody, and I think that's what the conversation needs to be. It needs to be big, it needs to be bold, and it needs to be across all parts of the care system.
Thank you. So just moving on from questions from the audience. So the first question is to Fiona. If this is such a huge opportunity for spotting inequality and access issues, what should we all be doing about it?
Well, I agree with what everybody else has been saying. We should be using the data. We should be using shared decision making. We should be seeking to make every contact count. We should be seeking opportunities to change that conversation, to enable patients around self-care, as well as engaging in effective shared decision making, as well as knowing what's happening within their population, knowing what the data is saying.
Thank you. And next question to Tim. Where do you see unwanted variation in 10 years' time? If Tim's still there. If not, I will move on, I'll come back. So a question for Andy. So community providers often lack the quality of data seen in hospitals. Do you see this as a challenge to the type and rate of transformation that Tim described, and how will you drive that change with that deficit?
Yeah, it's a massive challenge. It's a huge challenge that we have in the primary community care space. We've got within the Best MSK Health programme, we've got a work stream led by Chris Mercer focusing on primary community care, and a work stream focusing on data and metrics led by one of our analysts, Neil Parkinson. And they are working with all the stakeholders involved in the project, including Right Care and Girth, to co-produce a robust primary care and community care data set. Now, we as part of this, we need to make best use of the model health system to align with the secondary care plan, and we need to join things up to ensure that we are relating primary and community care data with secondary care data, so we can measure the quality of the whole system and the productivity and performance across the whole system. To enable that to happen, there's a combination of things we've got to look at. We've got to look at commissioning and making sure that commissioning at place level through ICSs and at PCSN level focuses on the collection of the right data and measures using that data. We've got to focus on working with CQC to make sure that we are looking at quality of services aligned with that data, and we've also got to enable local leadership, and it all comes back to leads, and I'm sure the majority of leads in the MSK world want to be collecting this data. We need to bring down the barriers to enable it to happen.
Thanks, Andy. Next question to Tim. Tim, where do you see unwanted variation in 10 years' time?
So I think if we get this right, I think we'll see significant improvement in patient outcomes, patient care. And as James says, we know that outcome over cost is value. And we've got to make sure that we spend every pound of NHS money, which is taxpayers' money, our money, as wise as we can. If you said to me, are we doing that at the moment? I think there's the variation shows that we can make significant inroads into that. And I think to do that, we've got to, or as James says again, all own the problem across the whole system. And we've got to change the narrative, actually. What we've got to say is, instead of saying, well, this is too difficult, we can't be done. As I said at the beginning of my talk, in 2007, we had 587,000 people waiting longer than 52 weeks. So we've done it before. We need to change the narrative, how we can do it. We've got the data now to do it, and we've got to change the drumbeat. So we've got to have a relentless drive of using this data, adding to it from the work the great work that Andy's doing. So we have a whole system wide approach or model health system, which is regularly updated, shows the variation, who's doing it best, and then we learn from those best people, and then we just industrialize it. So I think we are now in a completely different space to where we were in 2007. So if we change the narrative, get the drumbeat, relentless drive on it, and everybody looking at the data, so no one can say when I go and visit a system, do you know, Tim, I haven't seen that data. Well, frankly, that is no longer acceptable. We have invested huge amounts of time, both human and money, to develop these data sets, and it's not going to be acceptable not to look at this data and utilize the data to drive change. So I'm excited.
Thanks, Tim. No, it does sound very exciting, the whole process. The next question is to Freddie. Freddie, you mentioned the feeling you have to fight the system. A lot of people don't have to do that, have the ability to do this. So what can they do?
Yeah, it's a really good question. It's really difficult for people in that situation. I think it's partly why not just involving patients, engaging with patients at ICS level is important, but actually in the voluntary sector and those patient organisations that can speak on behalf and represent people who can't do that directly, actually making sure that they are involved in the system at local level is really important. And I think, there are some programs out there. I know NHS England has one, and some patient organisations developing them to develop kind of patient champions, because some people, may not feel like they have a voice now, but actually they could be an amazing champion for patients themselves and others. So I think it's supporting people to develop their voice as well.
Thank you. And another question for you, Freddie. You also mentioned rural and deprived areas of the country are worse. I'm not sure it's as simple as where you live, of course, but surely there are some quick wins we can put in place to help. That's a question.
Yes, I think on neurology, the girth report has some good ideas around workforce, where it is difficult to recruit, for example. So I'd kind of point to that. I'd welcome any other ideas from the panel.
Does anyone else have anything you want to add?
Yeah, it's Tim Briggs here. So I think with what's the Freddie's talking about the neurology report and all the national reports, all 31 of them, they talk about the workforce and the variation. And one of the biggest things we can do is, as Freddie says, get individuals where trusts are struggling to recruit, have joint appointments with teaching hospitals, so that they absolutely bring those skills from the teaching hospital into the DGHs, some of which struggle. They're usually on the coast, all right? And the other thing we need to do that not just with consultants, we need to do that with all staff, so that we can have training staff in the teaching hospital, the DGHs, so that we have shared appointments and we get the skill set, the right people we need to drive up standards. It'll come down to people.
And just to come in there, we have an opportunity. So stars are aligning because of the excellent work that HE are doing in the AHP space with regard to frameworks for capability, not only for FCP, but for advanced practice, consultant practice are part of this. So aligning the work and the workforce strategy with that work, with what Tim has described, can help us look at things in a different way.
Thank you. Just another question that's perhaps to Andy and to Tim and perhaps James is accountability for this change is key, otherwise it's rhetoric. Who owns this at a local level?
Should I come in first? The fluffy answer is we all do. I think everybody involved in care should own this. The realistic answer is we need to enable a leadership structure to enable this to happen, which is one of the things we're working on. We're looking at a network for MSK through the regions and ICSs that is appropriately resourced, funded, has the right analysts around it, the right project managers, who we top down can hold to account about what's going on. But there is a balance here, isn't there? Because there's the top down accountability, but there's also the bottom up engagement, and we've got to get both right. The risk if we don't is we try and put square pegs around holes. So there is a balance to be found.
So I'll give I think a harder answer, if I may. So the whole program is regionally led, system delivered, and girth enabled. Okay, but what we've got to start doing is making sure we hold people to account to deliver. And too much in the health service has been failure to deliver, and then we just wrap another layer above it because they haven't delivered. There has got to be, as I said at the beginning, a relentless focus by all of us for the next 3 years, because that's what our patients want, that's what our patients would expect, and that's what the taxpayers would want us to deliver. So we cannot accept poor performance anymore by either clinicians or our managerial structures that support that. It's got to be working shoulder to shoulder to deliver, and there's no doubt on the HVLC programme I'm going to be held to account for that nationally, but in turn I'll be holding the regions, the systems and individuals to account to help me deliver it. So I think, as Andy says, we all own the problem, but we've got to understand we're all accountable to deliver this.
And just to come in, that's where the data bit is so important, and the ability to evaluate where we are now and the impact we can provide, along with a leadership framework to enable that accountability.
Thank you. James, Fiona, Freddie, anything else you wanted to add to that point?
Yes, it's James. So I suppose my thought is there's sort of professional leadership accountability for our organisational behaviours. So I feel accountable for what happens within my CCG commissioning world. I feel accountable for the decisions made in my general practice, and I hold to account my local trust for their behaviours and their clinical behaviours. So they are different, but there is a pathway of things that happen here that culminates potentially in someone having an irreversible operation. And at every point that everyone touches that patient, they're going through a gateway. And I think at every point that the person that does that, the individual as well as the organisation needs to be responsible for what they do or say and the outcome that creates. Because ultimately, when you take someone's knee out, you can't put it back. So it is a one-way ticket. I think it's important that at the last stage of that, when we get into consenting for operations, that consenting is almost a check that we believe that has happened at every point of the process and we've delivered that, as opposed to just the surgical statement of that. It almost needs to be a pathway check, and the ability therefore for the surgeons to call out other parts of the system. The accountability needs to be run up and run down.
So Marwan, can I just comment on that? And James, you're absolutely right about that. But just for information, when I first looked at the independent sector, looking at NHS patients, right, that they were treating, and they were doing huge volumes, the variation amongst independent providers doing NHS work is significant. And the very first one I went to where their outcomes for knee replacements were poor, right, one of the worst 8 in the country in terms of 5-year survivorship, what they were measuring was inappropriate for the CCG. They were measuring DVT rates at 30 days, then the car parking and the food. So what we've got to make sure is we've got to measure the right thing every time we do this in order to make sure we squeeze out the unwarranted variation. What we can't afford to do is measure the wrong thing.
And just to come in, it's a really interesting chat. Key to that, and it's a point James made, is commissioning. So in the primary and community care space, some of the drive for the heterogeneity we have in delivery, which is right because we have difference in populations and we have different resources, but the heterogeneity in outcomes and experience is wrong, is how commissioning has worked. So one of our prime focuses in terms of accountability through that leadership network is place level commissioning. Now we've got to work out how that works in the new ICS system and fundamentally how the ICSs integrate with the PCNs to optimise primary and community delivery.
Thank you. James, just following on from what you were talking about knee replacements, one of the questions, statements from the Q&A was that the best clinical advice I was given by a surgeon was you are not a good surgical candidate, meaning given the interventions that had already been made, my best options were to understand that this is as good as it gets. Do you think that aspect of, and just moving on again from the rest of the chat in the Q&A, do you think that primary care is doing what it can to support self-care to enable within shared decision making? Do you think primary care is doing everything it can be doing, or could it be doing more?
Do you want the short answer? No. Can they do more? Yes. But I think that's, in some ways, I think it's slightly unfair to single out primary care, because I think this goes across the entire spectrum. I think we can do better at every level. I certainly don't think self-care is a primary care owned domain. I think that goes across. You can certainly, in my secondary care specialist clinics, self-care is still a key part of what I would be expecting people to do, and I see myself as an enabler to do that. But I think for me there are issues of resource, time in primary care and across the system, but I also think there's understanding education. I think people genuinely believe that when the X-ray comes back and it says severe osteoarthritis, that means they need a knee replacement. And I think we need to educate, we need to understand, we need to be in a position where within our systems, each part of the system talks to each other, so we feed back to each other. I think the data that Tim talks about is absolutely key, but it needs to be live, it needs to be meaningful. So it needs to happen in a timely way, so that the interventions that happen at certain levels, the outputs are visible, and somebody's able to say that actually what's happening right now isn't right, so change the dial, move something, see and learn from it. And I think in the last 25 years, primary care and secondary care have been divided and conquered by Lansley and other people in the political spectrum, and actually we don't talk to each other in the ways we used to. We're not even allowed to write letters to named people anymore, their dear colleague. So I think we need to get back to that place where we're honest and talk to each other and give each other proper feedback, so that we do a better job. So that was my long answer. We can do better.
Thank you, James. Final question from the question and answer for Tim is, it may be useful to gather data from private providers, as often they pick up some of the weaknesses within the system. Is this going to be approached too?
Yes, it is. So the idea is that I've already reviewed orthopedics and spinal surgery in 4 of the big private providers across every single independent hospital for each of the providers, and that data on volume data, like in the NHS, is now going to the model health system. And then what we want to get into there is we want to get into the theatre data, because what we want is a level playing field, consistency, so we're producing, as James says, the best outcome. So I can tell you from being a consultant at a tertiary referral hospital at the RNOH, 20% of the knee replacements that come are very unhappy when they come for a second opinion, and the causes for that are multifactorial. But it's either the surgery hasn't been done particularly well, or it shouldn't have been done in the first place. And so what we've got to do is, as James says, work together to make sure we operate on the right patient at the right time. And that's why the work that Andy's doing is going to join all that up, and then we need to do it in the other specialties in exactly the same way, so we get a consistency across the country using those pathways, so we don't have the unhappy patients that we do see because of inappropriate decision making or inappropriate or poor surgical performance.
Thank you, Tim. And final question for Andy. Are the formation of ICSs going to make it better or worse?
Potentially, yes. I think it represents a massive opportunity, because look, if we take a step back, musculoskeletal conditions are driven by pain. Pain is driven by multiple factors across the biopsychosocial spectrum. We have talked at length about a preventative population health approach. We've talked about supportive self-management. We've talked about shared decision making. That requires integration between the health sector, the social sector, the third sector, and the ICSs. The ambitions of the ICS is to enable that to happen. Now, of course, that's very easy to say, and there's the nuts and bolts of making it happen and supporting ICSs to do that in the right direction. And that's really one of the aims of our programme, and I suggest it's probably also the aims of Tim's work too. So I think the ICSs represent a massive opportunity. The risk and the challenge, as mentioned before, is how ICSs integrate with PCNs to make sure we don't move the challenges associated with commissioning described to a more local level.
Thank you, Andy. And that's the end of the Q&A questions, and it marks the end of the event today. Thank you to all the speakers for attending and sharing your thoughts with us and that lively Q&A discussion. And thank you very much for joining the webinar. Please don't forget to fill in the feedback survey. It just takes a couple of minutes of your time, and it really helps us improve on future events and understanding what type of topics you'd like us to cover. We hope you can join us for another webinar in the future, and you can see the slide in front of you, which is our next one on the 19th of January on mental health, followed by health inequalities in March next year. Thank you once again, and please look out for the recording in the summary Q&A, which will be on our webpage soon. Thank you, everybody. Goodbye.
Thank you.